Today we are going to discuss about the pleural effusion and about pleural effusion. Before knowing that, we need to understand that this is the lung. Lung has a lung and it has the outer two layer of parietal pleura and visceral pleura. This is the parietal pleura and this is the visceral pleura. Visceral pleura are embedded with the lung parenchyma, whereas the parietal pleura is separated, and between the gap between these two layers is known as the pleural cavity. Normally, the capillaries that supplies the blood supply of the parietal pleura has the capacity to release to secrete some fluid into the pleural cavity. Normally, pleural cavity have some small amount of the fluid is present there. This is normal, and that fluid is usually drained by the lymphatics that is present over the parietal pleura. So it is so simple. That is, parietal pleura is there. It has the blood supply. The capillaries is there, and the blood that leaches from the capillaries goes into the pleural cavity. This is normal secretion. Okay, and that same fluid is drained by the lymphatics. It is a continuous process. The small amount of fluid is always present inside the pleural cavity. But if that is present in excess amount, then that is called pleural effusion. Normally, for understanding that, also there are the three places by which there will be the more pleural fluid inside the pleural cavity. One will be the more secretion from the capillaries. The secretion is so more that it can the lymphatic drainage, which drains normally at the rate at which the lymphatic is drained exceed from the secretion. Normally, you have to understand that the lymphatics has the capacity to raise the fluid 20 times more than the normal secretion rate. If you know about the liver, when we have the prehepatic jaundice, that is hemolytic jaundice, in that case, liver has a capacity to conjugate the bilirubin 20 times more than the normal daily rate. Same as here, the lymphatic has the capacity to drain the pleural fluid 20 times more than the usual daily rate. Okay, if the capillary fluid leakages more than even than the 20 times drained by the lymphatic, then it gets accumulated inside this pleural cavity. So one mechanism is this. Another will be the leakage of the fluid from the visceral pleura and into the pleural cavity. But this is usually not a normal mechanism. It occurs in pathological condition. There may be also another mechanism by which the fluid enters the pleural cavity is below the diaphragm, through the diaphragmatic pore. Usually, a patient with ascites or cirrhosis of the liver, there in 5% of the cases, the fluid leakages from this diaphragm, the small pores in the diaphragm, and then goes into the pleural cavity. So when a patient presented, you will have some liver cirrhosis or ascitic patient, then they may have this pleural effusion into the right lung, mainly into the right lung. So you are understanding this. Okay, so there are the capillaries, lymphatic drainage system. When there will be, now let us discuss about this. Okay, when you come to know a patient is having pleural effusion, pleural effusion can be a patient may come to you with a dyspnea, may having saying that I have respiratory difficulties and difficulty in breathing. You do X-ray may be normal X-ray in the PA view or in the lateral decubitus X-ray, or he may present with come to you with a CT scan or USG. You came to know that he is having a pleural effusion. Okay, the first aim is to decide this is a transitive or exudative. This is the first aim of your diagnostic process should be to decide it is a transitive or exudative. Okay, for deciding that, you need to tap the fluid and then analyze it. What you will analyze? The analysis should be it is either transitive or exudative. On what basis it will be analyzed? We will examine the fluid. There will be the protein fluid of this pleural fluid protein and the serum protein. If pleural fluid protein and serum protein is greater than 0.5, then this indicates that it is a exudative fluid. Or if the pleural fluid LDS is by serum LDS ratio is greater than 0.6, it also indicates that this fluid is exudative in nature. Or if pleural fluid LDS is greater than the 2/3 of the normal or the upper limit of the serum LDS, then it is also exudative. If any of the criteria is present, then it indicates that your pleural fluid is exudative in nature. Why we have differentiated this is exudative or transudative? The importance is that we came to know the cause of our pleural effusion. Okay, suppose it is transudative in nature, means it doesn't fulfill any criteria. Okay, then we'll say okay, it is a transudative in nature. If it is transudative in nature, then what happens? The cause will be mainly, there are many causes, 5-6 causes, among them 3 are the major causes. One is the heart failure, second and third is the liver cirrhosis and nephrotic syndrome. Now let me explain it. A patient having the heart failure, suppose heart is not working properly, there is the backward pressure towards the lung blood vessels, then there will be the more pressure inside the blood vessel. You always know that blood vessel, the fluid is maintained inside the blood vessel due to the two force. There is a one force, that is hydrostatic pressure. It always pulls the fluid inside the blood to outside. If this is the blood vessels, okay, hydrostatic force will pull the oncotic pressure. So the hydrostatic force will always want to pull this fluid outside this blood vessel, but oncotic osmotic pressure, this will always try to this oncotic pressure. This is due to the protein content, and what it will do, it will try to keep this fluid inside this blood vessel always. Now what happens? This hydrostatic pressure, there is a difference between this hydrostatic force and osmotic pressure. Next, if this difference will increase by any mechanism, by due to the increase in heart failure or decrease in this osmotic pressure, then the fluid in the blood vessels will leak out. So what happens in heart failure? The patient blood vessel is inside this is lung parenchyma. Now due to increase in the backward pressure, the hydrostatic pressure is increased, and since hydrostatic pressure is increased, hydrostatic force is increased, now fluid is leaked from there and enter into this. Okay, so the fluid has been leaked from the basilar pleura, that is not from the parietal pleura. Parietal pleura and lymphatic drainage is normal mechanism. Okay, but when we talking about the heart failure, then in hydrostatic force will be hydrostatic pressure. Hydrostatic pressure will try to pull the fluid outside the blood vessels, and same the fluid is pulled out and it is accumulated inside the pleural cavity known as pleural effusion. This is due to a heart failure and it is transudative in nature. This is due to heart failure and it is transudative in nature. Other cause that will be this osmotic pressure. The osmotic pressure will be decreased. This osmotic pressure is maintained by the protein contained in our blood. The protein content will be decreased. In which condition? If the liver is unable to secrete the protein, then the protein amount will be decreased in our blood. Or in the nephrotic syndrome, there is a loss of protein from the kidney, so there is hypoalbuminemia, and because of this, due to the low albumin content, now osmotic pressure is not maintained, this oncotic pressure is not maintained, and fluid is leaked out. It has the oncotic pressure has been decreased, and because of this difference is decreased, and so your fluid has leaked out. So you have understood that okay, if the visceral pleural hydrostatic heart failure, how the blood how this pleural effusion occur. You also know that if it is transudative, then we will know that this oncotic pressure has come down. So due to oncotic pressure has come down in the liver cirrhosis and nephrotic syndrome patient. Okay, so we have came to know about the transudative. There are other causes as well. So we have discussed about normal fluid secretion and then lymphatic drainage. Now we have discussed about the through the visceral pleura. There may be the other infection like parapneumonic effusion and other that will lead to this secretion from the visceral pleura. Okay. So if we have came to know that after examination, if it is exudative, if it is exudative in nature, then it will fulfill this pleural fluid protein by serum protein is 0.5, or say pleural fluid LDH by serum LDH ratio is greater than 0.6, or pleural fluid LDH is greater than 2/3 of the normal limit of the serum LDH. These three criteria will tell us that our pleural fluid is exudative in nature. Now, what to do is exudative pleural fluid due to lot of reasons. The reason may be due as normally bacterial infection, it may be viral infection, it may be fungal infection, it may be parasitic infection, any infection normally, but the most of the causes bacterial infection. Then malignancy. In malignancy, there will be due to the lung cancer, breast cancer, lymphoma, mesothelioma. Okay, these are the reasons for having the exudative pleural effusion. Then there will be the collagen muscular disease and trauma. Okay, and there is another term is called as chylothorax or lymphatic. What happens if there is any problem in the lymphatic duct? Suppose the lymphatic duct has been plugged, then drainage has been plugged. Drainage will be again the fluid. Either there is no pathology, but there is a secretion of a small amount every day to maintain inside the pleural cavity. If you are not draining it, then it will accumulate and again cause the pleural effusion. Okay, that is one reason. This thoracic duct inside, there is a damage to the thoracic duct due to thoracic surgery or say trauma or say any malignancy may also lead to the injury to the thoracic duct. In that case, that is called the chylothorax and it is milky white in appearance. If you examine and see the triglyceride level of that, will be increased. That is about the chylothorax. There is another term called hemothorax. Hemothorax is the blood content is more in the pleural fluid. If you examine it, it will look like hemorrhagic. If you examine further the hemocrite level in the pleural fluid and the peripheral blood, the hemocrite level of the pleural fluid, if it is more than 1/2 of the peripheral hemocrite level, that indicates that it is hemothorax. Understood? So we have to take down transitive, exudative, lymphatic. Exudative means like one of the following criteria. Okay, there is one thing that you need to understand, that this is the criteria of exudative, but in 25% of the cases, 25% of the exudative fluid can be transudative. Means can be transudative. What does it mean? What I'm going to tell you that if you examine the pleural fluid and it comes between the one of these three criteria, then you will say okay, it is exudative fluid. But sometimes transitive fluid can be falsely recognized as this exudative. In that situation, what you will do? You will measure the serum protein and pleural fluid protein. Serum protein is normally 6 to 7.8 gram per dl. If the serum protein minus pleural fluid protein is greater than 3.1 gram per dl, means that serum protein has more, in comparison to this pleural fluid protein, if serum protein is more than 3.1 gram more is there, that it is usually indicate that this is transudative. Okay, this pleural fluid protein is less, more than 3.1 gram less than comparison to the peripheral, and it indicates that it is transudative. Okay, so that you have understood. Now if you goes to the